Everyone. Sorry about the few technical issues here. So we have a fantastic lineup of speakers today, and thanks so much to everyone who came in person and everyone who's participating remotely. We have a slight schedule change. So Dr. Duell will be giving an overview of CTX first, followed by Dr. Zipporah Felix-Akai from Israel, who will be talking about chenodeoxycholic acid therapy in CTX patients during pregnancy. And then Dr. Brian Wishart will be giving an overview of functional and symptomatic management in CTX, followed by Dr. Bonnen, who will be talking about evidence to support similar progression of CTX within families. Then Dr. Larson will speak on lessons for implementation of newborn screening for CTX diagnosis and management of newborns with CTX, followed by Dr. Vaz from the Netherlands, who will talk about some exciting results of pilot study screening 20,000 newborns for CTX. And then Dr. Joseph Orsini will be giving us an update on a prospective pilot study screening New York State newborns for CTX. And so I will try and keep everyone on time. And I just wanted to check the remote participants were all there. So I know Dr. Zipporah Felix-Akai has joined us. Dr. Bonnen, are you there too?
Yes, I'm here.
Fantastic. Dr. Vaz?
Present.
Great. And Joe Orsini?
I am here.
Okay, wonderful. Well, we can begin. Thanks, everyone. And I think you can put the presentation up now.
Okay, wonderful. Can you hear me okay? Is that good? So my name is Bart Duell, and I'm really pleased to be here to speak to all of you today. It's really a great honor to be invited to give this talk, and wonderful to meet so many of you as well at this session. And my task is to give an overview of CTX, and I think many of you have been on this journey for a while and know a lot about it already. But I wanted to cover some of the things that I think are important from my perspective. And I do have these disclosures, and I'll jump right into one of the cases that I thought is informative in a number of ways. And the one thing I'll say up front is the estimate is that the time from onset of symptoms to diagnosis in many cases can be 10 to 20 years. And the questions that were being asked earlier about how do you find an expert are very relevant, because early on it's difficult to know what kind of expert you need. You know you need an expert, and none of the doctors know where to go. So we're trying to work on that and come up with ways to make this easier for everyone. So this was an 8-year-old boy who before we saw him was referred to various doctors because of declining health since the age of 3. He'd had chronic diarrhea since infancy. He'd been normal compared to his siblings until the age of 3, and then started lagging behind his friends, developed some mild learning disabilities, had an abnormal gait, couldn't walk in a straight line like everybody else, and saw many, many consultants. He just continued to get worse, and at the age of 7 was noted to have declining vision. By the age of 8, it had gone to 20/250 on the right and 2100 on the left. So 20/20 is normal, and many kids are often 20/15 or perhaps even better. So he was found to have cataracts. He did not have tendinxanthomas at that time, but this was really a stroke of luck, and it was really thanks to Travere, formerly known as Retrophin, which was doing a study to screen for CTX. And I'm sorry, I will take this off. I should have done that earlier. Excuse me, a study to screen for CTX in children with bilateral idiopathic, i.e. unexplained cataracts. And we were not actually doing the study yet, but our ophthalmologist who saw this young boy said, aha, let's test for CTX. And guess what? His plasma cholesterol concentration was 2.43, normal being up to 1. He had abnormal bile alcohols in his urine, which is another marker for CTX. This number was done after he'd been on treatment for more than a month, but it was still 20 times normal. And then he had confirmatory genetic testing. Now, for me to present the case in this way makes it sound really easy, right? He had some symptoms, he got evaluated, and now we know he has CTX. But his pathway to getting this diagnosis took more than 5 years, 5 or 6 years. And that was despite seeing a geneticist, seeing other specialists. And so my point from this case is twofold, though. One is to give you hope that there are easy pathways for this to happen. But the other is to be realistic and say this was a hard path to make the diagnosis. And in retrospect, it's obvious, right? All of you who know about CTX, you say, what else would it be? So he was put on chenodeoxycholic acid, and this is the other positive aspect of the case, is that he really did dramatically better. So his number of bowel movements went down, his school performance started improving, he was able to pay attention better in school, his gait and balance improved, his growth normalized, as I'll show you in a minute. And at this point, he's doing well. He's just a happy, cheerful, active kid at the age of 14. So a huge success in that regard. And also, I don't want to discourage some of you because I know you've had kids who haven't done as well. And some of that's related to the type of CTX that's present. Some of it's related to delays in onset of treatment, and then other factors we don't fully understand at this point. And this is a little small perhaps, but the point of this is to show that he was down at the bottom percentile. I don't know if my pointer works, I guess not, but for his height, that bottom line is the 5th percentile. So he was shorter than 95% of kids. And once he got on treatment, he started growing better because he was absorbing nutrients better as a result of getting chenodeoxycholic acid. So in the presenting symptoms really vary by the age of onset. And I'd emphasize that everybody is different here. There are people with CTX who have minimal symptoms, and some have every symptom there is on the list. So diarrhea is really common. Failure to thrive is pretty common, meaning just not doing as well as a normal kid. Having elevated bilirubin levels can be seen. Even more advanced liver disease can be seen. High bilirubin is a sign of some liver dysfunction. Cataracts are very common, and that's an important clue to screen for CTX. And then the other developmental problems as well. In adulthood, things tend to get worse, but even that being said, there are some adults who get diagnosed at age 30 and they've had minimal symptoms their whole time. And so they don't have all of these, but neurologic dysfunction tends to get worse. And ataxia, spasticity, that refers to inability to move in a straight line. And so there's kind of jerky motion. Intellectual disability, dementia, psychiatric symptoms. There's some discussion that even ADHD might be a subtype of this. Early cataracts, xanthomas we haven't talked about, but those are deposits of sterols in the tendons themselves. I'm very sorry. And then it's not common, but early heart disease can actually happen. And so that's something that is often to the periphery for many people because those are not the most obvious symptoms for the patients. Seizures, and then osteoporosis. Nobody really understands the mechanism for that, but osteoporosis can be a complication as well. Now, in theory, all of these can be reversed. Oh, thank you. Reversed or at least the progression stopped by being on treatment, but everybody's different in that regard as well. And Dr. Salin was mentioned earlier, and Dr. Steiner also was the co-author on this really very nice article in which this figure nicely shows the time scale and the prevalence of different symptoms in CTX. And the diarrhea at the top is one of the earliest signs. And then going down at the bottom, dementia, some of these other neurologic complications tend to occur later in life. So what's the biochemistry? It's a recessive disorder, meaning you need an abnormal gene from mom and an abnormal gene from dad. And from what we know, being a carrier tends to be neutral, but there's some ongoing discussion about that, and that Dr. DeBarber has shown some abnormal biochemical levels in some of the carriers, but it's not enough to cause a clinical condition. It's caused by mutations in the gene that gets referred to as CYP27A1, refers to things that are in what's called the cytochrome P450 system. This is a system of enzymes that are important in the liver. And this gene encodes an enzyme, a production of an enzyme known as sterol 27 hydroxylase. And that enzyme is important for producing bile acids. And if it's defective, then things upstream to that accumulate, and including cholesterol and some other metabolites that we measure. And then I talked about these other things already. I know this is the most important part of the talk for all of you to, no, I'm just joking. Even when we show this to our medical students, they kind of groan and their eyes glaze over. But I'm showing you this just so that you understand that we really do know a lot about the biochemistry, and understanding these kind of pathways has helped people like Dr. DeBarber and others develop new assays that might be more sensitive or specific for diagnosing and identifying the response to treatment in CTX. Cataracts can occur, and you can see kind of a stippled pattern to the back of this pink part of the eye. That's the lens in the eye, showing kind of a characteristic sort of cataract that can occur. Tendon xanthomas are shown in a dramatic way here early on. They're much smaller and subtle. And in some cases, you cannot even see them. You can only feel them. And here they are on the ankle on the left, and then on the elbows on the right. And then through kind of an odd quirk, the xanthomas can develop in the brain, specifically in the cerebellum. And the arrows here point to these white intensities in the cerebellum. And the cerebellum is important for controlling movement. It's what allows me to reach and touch my finger, for example, to take a step, one foot in front of the other. And so to the extent that function of the cerebellum is impaired, then people can have movement disorders. And I mentioned osteoporosis earlier. These are actually images of the young boy I was describing. I don't think he has osteoporosis. He was, once he got on treatment, became an active, vigorous boy, and made an accident jumping over something, as happens, and fractured his leg. Now, we published a case a number of years ago summarizing 43 cases of CTX, and these are not optimistic, I guess. One is that the mean age of diagnosis was 32 years, but I know from our center we had 18 cases in this, and this dated back to the 1970s, even before my time. And so the mean age of 32 was before we knew a lot more about CTX. Half of the people had diarrhea, 74% had some kind of cognitive impairment, subtle in some cases. 70% had cataracts, almost a little more than 3/4 had xanthomas, 80% neurologic disease, and then 7% had early atherosclerosis. So I want to emphasize that again, that although it might not seem important, being aware and screening for atherosclerosis among older patients is important. This does not apply to somebody who's 20 or 30. It would be more like 40, 50, 60. Prevalence is rare. And there are some estimates that maybe it's 3 per million. I've put on here 3 to 5 per 100,000 in certain populations like the Druze that you'll hear more about later, up to 0.2%, really common. Another survey looked at over 200,000 patients, and the prevalence there was about 3 per 100,000. And then, as I mentioned at the bottom here, when this study was done by Retrofin, i.e. Travere, it was found that about 2% of kids with bilateral cataracts actually had CTX. So you go from 3 to 100,000 to 2% just with the clue of bilateral cataracts. Really very exciting finding. To diagnose it, you measure levels of cholesterol in the blood or the plasma. It turns out that some people can have normal levels of this and have other abnormal metabolites, so it's not exactly the gold standard. Measuring urinary bile alcohols is a very sensitive test for assessing the response to therapy, as well as diagnosis. And then I don't expect you to appreciate having the technical terms in here, but these are some of the things that we can also measure, including doing dried blood spot testing or checking these in plasma. And then genetic testing is nice. It can confirm the diagnosis. It's not essential in some cases, but I think it's helpful to try to do the genetic testing in every case just to have that final confirmation. The treatment is really easy. So it's a super hard path getting to the diagnosis. The treatment is basically giving back what's missing. Chenodeoxycholic acid is a bile acid. And if you take supplemental chenodeoxycholic acid, what it does is suppress production of all of those abnormal sterols that are causing toxicity in the brain and in other parts of the body. And early treatment's important, and therein is the biggest challenge we have in all of this, is figuring out how to diagnose people early. And in some people, like the young boy that I mentioned, his symptoms seemingly went away. In others, the symptoms get worse despite treatment. So we don't know in advance how that will come down, but the earlier the treatment is started, usually the better. And the amount of reversal that occurs depends probably on the age of diagnosis as well. And then continued treatment is needed during pregnancy. And I put this in as a prelude to what you'll hear about later. But the labeling for the medication says don't use it during pregnancy. But this is a case where we're giving back something that's missing. This is not a drug as in a foreign chemical. And so work is needed in this regard as well to ensure that people don't stop their treatment when they're pregnant. Babies don't do as well if treatment is stopped. And then I'm getting last minute. There additional treatments are needed sometimes, as indicated here. It's really case specific, but cataract surgery, obviously for cataracts. Some people need antidepressants, anti-anxiety medication. Sometimes the parents need these to help them deal with the circumstances. Muscle relaxants, physical therapy, speech therapy. Really, it's important to get the whole team together to help with all of these issues. And then for general preventive health, trying to eat heart-healthy foods is important. Regular physical activity, like we tell everybody else, don't smoke. General healthy living, it makes things turn out as well as possible. So in summary, CTX is on the one hand kind of a straightforward disease. We know the mutation that causes it. It's in this gene CYP27A1. The consequences are you get a defect in bile acid synthesis, and that amazingly causes far-reaching effects throughout the body that can include, in the more prolonged state, debilitating neurological dysfunction, xanthomas in the tendons and the brains, diarrhea due to the absence of bile acids. Bile acids are important for absorbing fat from the diet, and so absence of bile acids causes diarrhea, cataracts, osteoporosis, and then in a small percentage of people, atherosclerosis. And then the final point, again and again and again, early diagnosis is important and early initiation of treatment as well. So with that, I will quit. And I'm sorry again about the technical delays getting started on this, but really appreciate your attention. Do we have a...
So we have time for one quick question, just to make sure that we can get all the speakers in today. So
You need to use your mic so I can read the question. It's for you, Dr. Duell.
Okay.
Okay, so the question is, you mentioned that some people with CTX do not do as well, and that can be based upon the type of CTX. Can you please talk about the different types of CTX?
Yeah, excellent question. And I shouldn't have said it in that way probably, because the CTX is caused by defects in this enzyme, but the severity of the defect can vary from one person to another. And then I think we're still learning about this, but there seem to be other factors that may superimpose on this. So if we match people with the same mutation, one might have minimal disease, another may have more severe disease. And so it's kind of like other aspects of life. You know, we go through a hardship, go through something, some of us just bounce right back, others don't do as well. And so that's what I was referring to in different types of CTX. Thank you very much. Oh, another question. Maybe can we put it off to the end? Or?
And so Dr. Duell will be joining us for lunch. So I think just in the interest of moving along and keeping everyone on track with the other talks.
Thank you. So my name is Brian Wishart. I am a pediatric physiatrist. I work in the Leukodystrophy clinic at Mass General in Boston. And I'm going to present today talking a little bit about some work we've done over the last couple of years, trying to look at the more recent papers and talking with families about some symptom documentation, expanding that kind of list of symptoms that we're seeing, and then briefly talking and touching on some of the management recommendations that we're trying to put together, pulling from other fields as well as the CTX field. So these are my disclosures, and just briefly, you guys have had plenty of overview, so we'll be super quick on this, of what CTX is, but really, you know, coming from a rare genetic disorder affecting the brain, affecting the whole body related to this cholestatic and plaque development, these disease-causing compounds. So reported originally in 1937. There's lots known about the biochemistry, the genetics. There's not a ton out there, honestly, about the management of these symptoms. And so our hope with the work that we were doing over the last couple of years was to really highlight that high symptom burden that we're seeing in the CTX population from a young age that we've heard it sometimes all the way up through an older age, and how that sort of compounds as they're getting older. Providing that list of symptoms and then identifying gaps in our knowledge base and what we should be moving forward with. So we looked at a literature review of papers published on CTX from 2016, tried to extend a previous review that had been done and published in 2016 and just sort of compile the more recent literature up through that 2019 period. And then look at our symptoms, and we broke those domains down similar to other papers into neurologic symptoms, non-neurologic symptoms, and then psychiatric symptoms, which had been touched on, has been discussed, but we tried to get a little bit more granular with it. We also had the privilege of having several families involved with this early on, and so we were able to kind of tap into that personal experience as to what symptoms are we also seeing, and is this something that we should be looking for in the literature? And so we tried to do that. This is sort of a little kind of quick summary on what the historical symptoms are that we talk about, as you've heard in the last couple discussions. But chronic diarrhea, or from an early age, those bilateral cataracts, ataxia, so speech impairments, gait abnormalities, balance issues. We do hear about these corticospinal tract issues with spasticity, tight muscles that affect us, and then other behavioral, psychiatric, neuropsychiatric issues, impulsive behaviors, behavioral changes, and others that we dove into a little bit deeper. as well as xanthoma. So this was sort of our classic one. This is the list of symptoms that we tried to go through, looking at those neurologic symptoms, being a little bit more granular with things. We did try to pull in some more kind of catch-all symptom times. So psychiatric changes we put in at one, and then we had a whole area of more granular issues with that, from behavioral changes, hallucinations, agitation, aggression, and so on and so forth. And you know, looking at things like learning difficulties, ADHD, autistic features that might be more subtle, and was a little bit challenging at times, I think, when we were looking at the literature, and so on and so forth. We also sort of looked through and we did expand our chart review of our patient population. So we expanded it to, I believe, the full 10 patients, and looked at things that had come up in our clinic and discussions that we had had with our patients, and ones that were not necessarily in the symptom review that we were talking about at that time. And so there were a couple like bowel and bladder issues, Cialorrhea, some dystonia discussions that came up, and we tried to put in there. So I have a couple of charts that kind of compare our MGH cohort with the literature review. I will say I just noticed that Dr. Duell's paper, the 43 patients, for some reason that data did not get into these charts. So the research publication, we have it in there, but it's not, those patient numbers, those 43 patients did not make it into here. So it'll be a little bit lower than I think what it'll come out at the end. But you can see, you know, as we go through this, I think what we're seeing when we're looking through, and particularly as we've been going through our more recent visits, and we're thinking more about a lot of these symptoms, we're getting a lot more hits in terms of our chart review. Our psychiatric symptoms were really 100%. There was at least something, whether it was something subtle from behavioral changes to ADHD, learning difficulties, to more dramatic things. And I'll break those down a little bit more, but that was sort of our catch-all. You know, gait difficulties, that type of thing is something that I primarily focus on. And so we had sort of that catch-all of just general gait difficulties, and then breaking it down further into ataxia or dystonia or the cortical spinal tract symptoms on the front end, which would be spasticity, and other simple ones like of just purely describing a Babinski, which would be a long tract sign from the brain coming down. Tremor, Parkinsonianism, all of these could potentially be falling into that gait difficulty as well. And I will say also our MGH cohort is an older population. Most of the patients in that group are, I believe, from 30 to 60 or so, in that range. So we're capturing, I think, more symptoms as we go through that. When we looked at the psychiatric symptoms, you know, it really was often more on the subtle sides that we were capturing. So behavioral changes really were quite common. I think we saw a lot of impulsivity type things, sort of bad decisions in general life came up, though I don't know if that got captured here. But learning difficulties, ADHD were on the earlier side. Autistic features were things that we did see on the earlier side, even though it's on a lower percentage of patients that we're seeing. We did have several patients that showed outright agitation, aggression, that type of stuff. We did look at things like hallucinations and schizophrenic things, and we didn't find any reports in the literature, and none of our patients had reported any of that as we went through. When we looked at the non-neurologic, you know, it's a little bit different, I think, in our population of what we saw than what we're seeing reported in the literature as a whole, and then also even with the reports that we pulled out. But tendon xanthomas were actually relatively uncommon in our population. We only had, I think, 2 patients that did have xanthomas reported. The diarrhea, relatively common. Again, you know, it's an older population, so I think at times when it's that infantile, we're not necessarily getting great reports of that. But those parts that really weren't described well previously, the Cialorrhea, bladder dysfunction, were things that did come up, and we do end up having relatively frequent conversations. And I know at least one patient, which I think is the Cialorrhea, is on treatment for that, has gone through multiple rounds of atropine and further on into Botox injections and more interventional type stuff to try to help with his speech and swallow and all of those types of things. So, you know, when we're thinking about this, I think often when we talk about the treatment for CTX, CDCA is obviously up on the forefront. We know that it really can treat our biochemical abnormalities, ongoing research, but well-documented, notable effects on kind of ongoing symptoms at that time. I think the bigger question is, what is our reversibility? Things that have been ongoing, we know are not really we're not completely able to reverse. We might have benefit from them, but we're not turning these around. And so I think that, you know, when Dr. Wolf talks later about our newborn screen, this all speaks to earlier treatment. We did look at our cohort as well as the research publication in terms of how many were being reported with CDCA. All of our patients had been or were on CDCA at that time. I believe we had one patient that got switched to cholic acid at times. But looking further into the other treatment options and the other things that come on in terms of management, and what are we doing for the symptoms that we're seeing in these patients? You know, at the end of the day, it's not a huge population, even within our cohort, that is getting a lot of these treatments, whether it's spasticity. And I think some of that comes down to our variability in terms of presentation and which symptoms are actually presenting and are causing effect, as well as I think a little bit of hesitation, a little bit of slowness to these types of treatments in these patients because we don't have great literature. We don't necessarily know what the responses are. We know from other diseases like adrenal leukodystrophy that Botox has a bigger effect than what we anticipate when treating patients with stroke or cerebral palsy. And so we use a lower dose. And so I know from my treatment paradigm, I often am going slower in terms of our muscle relaxants for spasticity and other things like that. So there are patients that are getting treated with this stuff. I'd like to sort of dig in a little bit in terms of what I think about and how I think about treating, you know, gait abnormalities in particular. And I sort of like to talk a little bit about ataxia. I think it's a difficult gait abnormality to address and something that isn't done quite as often. We're quite commonly treating spastic gaits, tight muscles, that type of thing. But ataxia is not something that I think is as commonly treated, and it can be a little bit challenging. So we'll talk about both of those. You know, when I think about our gait difficulties, this is the paper from 2016 that we were sort of expanding on. You know, it really does break down, I think, into those corticospinal tract, that spasticity, and then that ataxia component that we're thinking about. So ataxia can be really broad. When we're thinking about the gait aspect of it, it really relates to difficulties with our balance, inconsistent gait patterns, discoordination, and difficulty with your balance, right? We're having falls, we're having difficulty moving forward. The question that I often get when we see patients coming in is, what should we do about this? You know, there's always a question about our muscle tone and that sort, usually not what we're addressing when we're thinking about ataxia. But bracing often comes up, and classically how we brace gait abnormalities is from AFOs, and we're bracing that ankle, which can affect our proprioception. There's good literature out there in the stroke research that says that, you know, a good AFO and SMO can give you improved proprioception. It can improve that ataxia in those populations. When you start thinking about ataxia that's much more bilateral, truncal ataxia, that sort, often bracing and tightening up and being restrictive at that ankle can sometimes have a opposite effect. You know, when we have this inconsistent gait pattern, and we're not typically walking in a very standard way, and we have a step that comes off, we need to accommodate for that in some way. And so usually what we're doing is we're using our ankle, we're using our knee, we're using our hip, we're using our trunk to make sure that we're keeping our center of balance where it belongs and not falling over. If we take that stiffer brace and we block out that ankle, we affect that knee, it really changes where we're able to accommodate our center of balance from. And you end up doing things really from your hip and from your trunk, and it makes it much more difficult to balance and that sort. And so when you look at spinocerebellar ataxia, Friedreich ataxia literature, there's a couple different options and a couple different ways of addressing ataxia. And often it's much more proximal bracing, things that are going to help us decrease that perturbations, decrease the amount of times that you're moving off. And so there was a nice, very small literature or comparative study on this knee brace. There were two different types that they did. One was a spring-loaded knee brace that kind of helped that knee get into extension, get to a much more stable position where you were locking out that knee as opposed to using your muscles to do it where you're getting co-contracture. And they compared the spring-loaded, which was much more forceful, versus a tension-loaded one, which was essentially kind of like K-tape, but a little bit stronger on the extensor surface. And they did show significant effects in terms of increased stability, improvement there. And so, you know, this is one option. They're quite bulky. This patient opted to continue with them afterwards. I think if we were to move forward, you could probably get something a bit more sleek. But I think the point that I bring across there is that, you know, the goal here is increased stability, proximally and decreasing all those perturbations, not necessarily locking something out in our classic manner of what we think about with bracing. The other one that comes up in the Friedreich ataxia world is this DMO, this dynamic movement orthosis. So this kind of bodysuit on the right, it's sort of made out of Lycra. It really restricts movement quite a bit and kind of wants to pull you back into that more neutral position. They can be fantastic. I use these often in our younger children with developmental delays that are, you know, on the weaker side, that have ataxia and that type of thing. They can be a bit challenging to get on. You can imagine going to the bathroom in them is a little bit difficult. So they come with a lot of kind of real world difficulties, but this is really where the literature is showing could be helpful. I think that there's room to improve here in terms of what we're doing, but when you're thinking about bracing and when you're thinking about that ataxic, what we want to be thinking about more is that proximal stability and decreasing that truncal ataxia, decreasing those perturbations, and bringing everything, that center of gravity, a little bit closer to neutral. And so when we think about the other types of bracings, our AFOs, this is really what we want to be addressing and what we want to be thinking about when we have more of a spastic component. We have more of a tightness. It's also wonderful if there's weakness, peripheral neuropathy, that sort, not something that we see quite as frequently here. But you know, these are kind of the slew of AFOs that you can talk about. An ankle foot orthosis can run from the metal double uprights on the outside, on the top there, to a solid molded AFO on that bottom right with the flag. Above that is what would be like an articulated brace, and then this white one would be a ground reaction, floor reaction one. All of these are different, you know, types. I think for the most part, and when we think about the ataxia, most of those are going to be much too restrictive in terms of the ankle, in terms of the knee component. And really, you should be thinking about the ones on the left there. So that white smaller one is an SMO, and then as we come down underneath the writing there, we have a UCBL, which is that yellow and blue one, and then just a foot orthosis. And these types of things can really help make sure that our foot is aligned, that we're using our muscles appropriately, that we're maximizing the proprioception and maximizing the amount of input we're getting back from our feet up into our body to know where we are in space. I will say for most of the patients that we've seen that have had symptoms like ataxia, that sort, that SMO is really the highest I have gone, because I think we end up worsening things. And I've learned that kind of through experience in a negative way. So always need to be thoughtful. When you start thinking about those coracospinal tract symptoms and that spasticity, that's when we really want to move to those other braces. And these are times when you can use these types of things to dampen that tone, keeping our ankles at 90 degrees, helping kind of push back our knee and push back that shin into a more stable position can be really helpful if there's weakness within our quads or there's tone within our hamstrings, and can make a big difference in terms of the efficiency and the amount of effort that we're putting into our gait and how much we're able to do once we get places. So I do think that bracing is a challenging thing, a little bit more difficult than a lot of people will discuss. I personally, if I can, often am doing this in a multidisciplinary way with a physical therapist and an orthotist there with me, watching the gait, going through it, and making sure that, you know, the goals that I'm aiming for are what are getting across to that orthotist. And there's been a few studies that have looked at how a brace is made and the effectiveness of it. And so in the UK, there's actually no physiatrists reported. And so they have these new 3D printing aspects to make braces, and they've shown better fit and better function and all of that. And so what we do in my clinic is I have the orthotist there, they cast them in the room, they then fit them the next time and are making adjustments with me there. And so making sure you have a good orthotist is the biggest thing that I teach my fellows, is knowing your orthotist, knowing who's making your bracing, and making sure that they understand your goals and what you're going for when you're going through this. So, you know, tone management, we just talked about bracing. Stretching therapy is a kind of the basis of this. For the most part, I have not gotten past that second stage there. This is kind of on the left, classically how it was thought about. We would start with that bracing, those very conservative measures, then move to oral medication, maybe some focal tone management with Botox and other things. I think it's much more a picture of the right, where you're really kind of pulling from different aspects. What's going to be best? We want to have some therapy. We need to have our bracing. Maybe we're really severely tight and we need to move to a backlift and pump earlier on. I don't think it's necessarily a stepwise thing, but what's appropriate for that patient from the beginning. So thank you. Hunters Hope has been supporting and had supported this project from the beginning. The MGH crew and a lot of the CRCs have really been very important, and then our families that helped contribute early on in terms of what we were looking at. So, any questions? Yeah, so. Yeah, there's a number of better options out there. Billy's shoe wear has become sort of the front runner here. It was originally made for spinal cord injury. It has the zipper around the top. They have a lot of different options. What I do recommend families do is go on the website. So they do sell them, I think, at Target, but Target specifically asked that they make a cheaper model. So they're usually not as durable. But they have ones that are wider. They have ones that are more durable for patients that are potentially scraping their toes. Nike makes a Fly Ease, I believe, that zips along the back, the New Balance, and there's usually just the wider ones that work. But Billy's are kind of where most families have been moving.
We have a question online. If you could repeat it into the mic.
Yeah.
So they can hear it. What is the UCBO?
Oh, so what is the UCBL? It's University of California, Berkeley Laboratories. It's essentially just a lower foot or a more substantial foot orthosis. So it comes up below the medial malleoli, those ankle bones, supports the posterior aspect of your foot where you're really capturing that backbone, that calcaneus, to make sure it's not moving too much. Not a ton of different applications, but when it's right for the right patient, it can make a big difference. And I think in the ataxic group, it does have some implications. But yeah, it's just a lower foot orthosis or lower orthosis that really captures that foot. So more than just the bottom, but less than that SMO that comes up over the ankle bones.
Okay, I think we have time for one really quick question, then we have to move on.
Do I have patients? Yeah, I think, sometimes the muscle strengthening is a difficult aspect because it's really coming from that neurologic input. There's nothing inherently wrong with the muscle. It's really the input and the control of that muscle that's an issue. I'll tell you, for things like CTX that are really metabolic in nature, I hesitate and ask for a lot of input in terms of changing diet and that type of thing. Yeah. I think those are generally always a good idea. And we talk about bowels and fiber and all that more than we should. So thank you.
Well, thank you again, Dr. Wishart, for that really nice overview. And so the next speaker will be a remote speaker, will be Dr. Penelope Bonnen, presenting evidence to support similar progression of CTX within families.
Okay, I'm just working on getting my slides so I can share screen. Okay. Can you see my screen now? Can you hear me?
Yeah.
We can hear you, we cannot see it.
Okay.
Oh, good. I'm glad I didn't say anything.
How do I share screen?
Down at the bottom,
Uh-huh.
there's share screen.
I don't see it.
Not seeing it.
Yep, now I see it. Thank you. Okay. Let's see.
Okay, we
Now?
see it now. If you do,
Do
yeah.
you have me? Good.
Yep. If you just want to make
Okay.
it full screen,
Uh,
center mode.
how? Can you tell me how?
Down at the bottom, bottom right, it's the one that looks like a computer screen. It's an icon on the bottom, looks like a computer screen. Bottom
No.
right,
Coming back.
right next to your volume controls on the bottom right.
Okay, I'm gonna stop share so that I get back here.
I believe you have to do it when it's open.
Okay.
Or yeah, you know what you can do? You can go to your view tab at the top,
Okay,
view the drop down, and then hit full screen, I believe, after you hit view
okay.
and your top control, your top tabs right there. Yeah. Oh,
Here?
nope, underneath, right underneath.
Yeah, this is my problem is I don't see my,
Well, you know what? I think it's okay. I think everybody can see this. Can we do? Yeah. So just, you're fine. Don't worry about it.
okay. Okay. Okay, shall we go ahead? Thank you for having me. I'm excited to be here to talk about the epidemiology and the genetics of CTX. Oh, that's what I want. Sorry, I'm coming back over here. Better. Okay. Okay. I'm Penelope Bonin. I'm from the Department of Molecular and Human Genetics at Baylor College of Medicine, and I've been studying the genetics of CTX for about 10 years. Let's see if I can go. These are my conflicts and my funding from the NIH. Okay. Okay, so just briefly, a rare genetic disease is one that has a frequency of about 1 in 20,000 to 1 in a million. Those are the sort of parameters that we place when we try to define what's a rare disease versus what's a common disease. And we know that CTX is a rare disease, but it was thought to be ultra rare. And so we did a study to find out just exactly what was the incidence of CTX. You have full screen? Better. Okay. And when we talk about rare diseases, we know that while individually they may each be uncommon, that when we combine the incidence of all genetic rare diseases, we have hundreds of millions of individuals who are affected globally. So this is truly an important health issue. Now let's talk about the incidence of CTX. Before I started to work on this problem, the incidence and prevalence of CTX had really been estimated through studies that were fundamentally epidemiological and based, or they were based on small sample sizes of patients who had come through a clinical setting. And anytime that you're looking at the incidence of something, you want to be mindful of your ascertainment biases and also the limitations in power of your analysis. And so we wanted to take a different approach to what had been done before. And we wanted to try to minimize the biases in the approach as much as we possibly could. We suspected that CTX was underdiagnosed. And so we felt that by strictly looking at the number of cases who've walked through a clinic would be already limiting us from the get-go. If we believe the disease is underdiagnosed, then counting the number of people who are diagnosed is a bit of faulty logic. And so we decided instead to take a population genetic approach and combine that with bioinformatics to estimate the incidence of disease. And what do I mean by that, by this population genetic approach? Because CTX is a recessive disease and you have to have 2 pathogenic mutations in order to manifest the disease clinically, there are people who are carriers who have just 1 pathogenic mutation and don't manifest the disease. And those individuals are walking around in the population. And so as the field of genetics and genomics has advanced and we've accumulated larger and larger databases that are population-based rather than disease-based, we can leverage those population-based databases to understand true allele frequencies in the population. So now instead of asking, how many people do we observe who are sick, who've walked into a clinic, we're asking a different question. We're asking, if we look at the allele frequencies of pathogenic mutations in a population, and then we do some of our classical population genetic calculations, how many individuals would we expect to have CTX? So that's the approach that we took. We also used bioinformatics to fill in the gap with, we start with the mutations that are documented in the literature to be pathogenic. We generate a bioinformatic profile for what those look like. And then we use that profile to go into, again, this population genetic database and ask the question, are there other variants in this population genetic database that look bioinformatically like they could be a pathogenic variant for CTX? And that allows us to, again, try to overcome some of the lack of information that we may not have a priori at the beginning of our analysis. And so we studied a database that has about 125,000 exomes from adults who do not have CTX. And we found the population frequency of pathogenic CTX variants and the variants that look bioinformatically like they would be pathogenic and cause CTX. And so that calculation and that analysis gave us incidence estimates that place CTX ranging from 1 in 135,000 to 1 in 460,000 in the white population in that population genetic database. And then the numbers are similar range for a Black population and a bit higher in incidence, seemingly higher in Asian population. But all of these ranges place CTX at a frequency that is more common than was previously thought. Okay, so now I'd like to change gears a bit and talk to you about CTX clinical presentation in families. We wanted to understand the genetic contribution to the CTX clinical presentation. So why study families? We study families to observe the clinical presentation among individuals who have the same CTX genotype, and they also have a highly similar genomic background. So, for examples, siblings share 50% of their genome. And so not only would 2 siblings who have CTX have the same CTX genotype, they would also share quite a bit of their genomic background. So we studied all the families that were published in the literature from 2011 to 2021. And we included a family in the study if they had 2 or more individuals who were genotyped and diagnosed as having CTX, and we found 40 families who met that criteria. Okay, so now on the right in the graph, I'm showing you the most common clinical features that we observed in this literature review. There were 40 families and there were 92 individuals that we studied and extracted their information as it was in the literature. So the number one most common feature reported in these 92 individuals was cataracts. That was followed closely by cerebellar dysfunction, and then pyramidal dysfunction, peripheral neuropathy, followed by diarrhea, psychiatric disturbance, and then xanthoma. And I wanted to note that we're using, when we use the term clinical feature, we're using these sort of high level binning. There are multiple ways to approach describing the clinical presentation, and you can be very granular and very specific. And that is very important in most contexts. We wanted to find sort of the higher level aspects of CTX. So pyramidal dysfunction may manifest in multiple different ways, but it can also be binned at that level of pyramidal dysfunction. And the same with cerebellar dysfunction. And so we were taking this sort of 10,000 foot view as opposed to a really granular view. So then we did a pairwise analysis of discordance amongst individuals within families. And so when we looked in a pairwise fashion within families, we found that most family pairs had a discordance score of 1. And what does that mean? That means that when we ascertained their clinical features, as I described in the previous slide, they shared all clinical features except for 1. So most of the pairs in our study were discordant in 1 feature, followed by pairs who were discordant in 2 features. The next most common result was that these family pairs were not discordant at all, and they shared all the features that manifested in those families. So most patients within the same family shared their major clinical features. And it's important to note, they may experience differing severity of those features and different age of onset of those features. We did not call something discordant if it happened at a different age of onset or with a different amount of severity. We didn't feel that we could confidently extract that information from the literature in most cases. And so we are binning simply for the presence or absence of a feature reported over the course of the lifespan that was reported in that paper. Okay, so here's an example. Most of the studies that have been done on CTX and reported in the literature report a really wide variation in clinical presentation. So how do we come to the conclusion based on this literature review that in fact, at least within families, family pairs share most of their clinical features? Here's an example. It tends to be what level you're looking of granularity and also your perspective. So here's one example. There's a paper published that described 40-year-old twins. And so they had the clinical description for those individuals up until the age of 40. And these were twins. And the title of the paper, and really the message of the paper, was that these 40-year-old twins had really highly different clinical presentation of CTX. When we did our analysis on this twin set, it's showed here on the left, the twins had in common that they both experienced cataracts, cerebellar dysfunction, Parkinsonism, which is not one of the most common features of CTX. So interesting to note, they both shared this lesser prevalent feature of CTX. They both had dementia, and they both exhibited some psychiatric disturbance. So the features they had in common were these 5 features, and the features that were different are shown here. One of the twins was reported to have one major severe episode of diarrhea over the course of his lifetime. The other twin was not reported to have any experience with diarrhea over the course of his lifetime. And then one twin had some pyramidal signs, and the other twin did not. And so based on our analysis, the discordance across the 12 most common clinical features of CTX was 2, diarrhea and pyramidal signs. So why did this paper publish this twins case study as being highly different clinical courses of CTX? Because the severity of these features were much more debilitating in one twin. The age of onset of the cerebellar dysfunction was much earlier in one twin. And this resulted in very real differences in quality of life and required supportive care. Okay, next. Okay, so this is now looking at this analysis from a different perspective. I've been talking to you about discordance and talking about how most of these family pairs, the discordance number was a 1 or 2. But the other part of the analysis is how much they have in common. So what concordance do they have? And so this graph shows for each of the family pairs, the number of features that were concordant in blue, and the number of features that were discordant in red or orange, whatever that color is. And so you can see here how many features each family presented and how many of those were concordant versus discordant. So for example, on the left-hand side of the graph here, you'll see the families that had the most, they presented the most clinical features of CTX, presented 10 features. And for example, in this family pair, the minority were discordant and the majority were concordant. But then we have a family here where the majority of the CTX features that were observed in that family were in fact discordant. And that family is an example of a family that shows high variability in clinical presentation. And you can compare that to, if you just look across the graph, most families had more in common than they did discordant. But we did observe a couple of families that had more discordance than concordance. Okay, so to summarize, when we calculate the CTX disease incidence, it is higher than previously thought. And when we look at the clinical presentation within families, we most of the time observe it to be more similar than different. And most patients within the same family experience the same major clinical features. And so some perspectives here, the disease incidence is higher. This is largely due to underdiagnosis and late diagnosis. Newborn screening is an important potential remedy for this and for the early intervention to help this patient population have a better, improved clinical course over their lifetimes. And the clinical presentation in families, really, we're taking a 10,000-foot view, and as opposed to a granular view. And one of the utilities of looking at that view from sort of high above is to say, what are the major features and what features are in common, to help, I think, families in the clinical community sort of have these guideposts that we can describe the disease from a high level view for families so that they can have some ideas of what to expect. And of course, we also observed that the severity of features and the age of onset may vary greatly, even though those features may manifest in most of the family members. And that's all. That's what I have for this morning. I'm happy to take questions.
Well, very nice work that for the first time shows that there may be a genetic link with the clinical presentation in CTX. Does anyone have any questions here for Dr. Bonner? So we have a question from the audience.
I was just wondering, were they planning to continue following up to see maybe like that twin, they were really different, but the stage changed with age, so age
So the question was, is there a component of this that is a time component? So that they follow the patients during the course of disease so that maybe, you know, later in the disease, they will have then presented with all the same clinical symptoms in the family.
So for example, the one example that I gave of the twin study, they were twins and they were both 40 years old at the time of report, right? And so that's a great example because not only are they genetically identical, but they are the same age at the time of report. Many of the family studies, obviously the individuals are different ages. And we only have the information that's in the literature, right? And so the older the family members, the affected family members are at the time of report, we do tend to see more clinical features manifesting. But there are families where their major features are their age of onset is younger than other families. And we can see that in the data as well. So again, this is a literature review and information extraction. So these are all snapshots. And some papers have reported patients at different ages, and we can't, or we did not account for the different ages in this analysis, except we did a pairwise comparison. And the pairwise comparison was only done for individuals who were within 1 decade of age of each other. So if we had siblings who were 20 years difference in age, we did not do a pairwise comparison for them. So every pairwise comparison we did, the individuals were a maximum of 10 years difference in age. Most of them were less than 10 years difference in age.
Okay, well, thank you again, Dr. Bonnen, for that very nice talk. So the next presenter will be Dr. Austin Larson, who's talking about lessons for implementation of newborn screening for CTX diagnosis and management, as we start to think about, you know, potentially implementing newborn screening for CTX.
So thank you all for being here and listening to this talk. Thank you for the invitation to speak here. I changed the title of this talk slightly to better reflect its content. So this is an ongoing project. So the way that I would represent it right now is that we're conducting a CTX systematic evidence review, and I consider this to be a resource for the questions that we need to answer in order to consider CTX for newborn screening. So my background is that I'm a pediatrician, medical geneticist, biochemical geneticist. I practice in Colorado. I see a couple of patients with CTX and actively manage them. And I've been engaged with this group for the last couple of years and working on this project. So in 2018, a lot of the folks in this room helped to spearhead an initial application for CTX to be included on what's called the Recommended Uniform Screening Panel for newborn screening. So the Recommended Uniform Screening Panel, which I'll just call the RUSP going forward, that is put together by the Advisory Committee on Heritable Disorders in Newborns and Children. So the response to the initial submission was that there were some aspects of CTX that needed clarification prior to reconsideration of this disease for newborn screening. So the things that needed clarification included the case definitions, evidence for the clinical utility of screening in a pre-symptomatic state, and some of the suggestions were to gather data on the spectrum of disease, the progression of CTX, and to try to make a better determination of exactly which patients would benefit from treatment. So we've been meeting for the last couple years, and so we're taking an approach to this systematic evidence review, and we've been guided by a methodological expert. Her name is Patricia Hine. She's at my home institution, University of Colorado. Christy Piper is a research librarian who specializes in systematic evidence reviews. And she's also assisting with the methodological piece of this systematic evidence review. So we have included all of the English language literature, both case series as well as case reports. And we've included that with any year of publication. So all three of those points are important as it relates to how these data look a little bit different from what you've seen from some of the other speakers today. We considered a CTX diagnosis to be clinical features in addition to either or both typical biochemical perturbations or biallelic CYP27A1 mutations. We excluded conference abstracts and publications where the diagnosis was not confirmed for the patient. We did an initial title and abstract review, followed by a full text review, followed by a publication quality scoring. And those three steps were conducted by Dr. Steiner, who's here in the room, Dr. DeBarber, who's here in the room, Dr. Patel, who is not here, and by myself. So at the end of that process, we had 248 publications that were included, which is a larger number than some of the other evidence reviews around CTX. We enlisted the help of three individuals, Tiffany Duque, Ana Pizarro, and Andres Riquarte. And the three of them conducted a data abstraction. They went through every single one of these 248 publications and abstracted data at the level of individual patients to construct the largest database of information about CTX clinical manifestations, biochemical manifestations, and genotypes. In addition to those, we documented the use of treatment and response to treatment in a subjective way. We did our absolute best to exclude duplicate patients, looking for citations within the publications, looking at overlapping author groups to look for evidence of the same patients being published in 2 different publications. And at the end of this process, we found that there were 1,054 published patients in the literature with a diagnosis of CTX. Some of those were in aggregate or had either no clinical data at all or very minimal clinical data. So we ended up with 873 patients who we felt we could abstract data at the level of the individual patient to construct this database. So for the most part, you'll notice there are 14 patients out of those 874 that had a clinical diagnosis only. So those are some papers maybe that had a mixed population of patients, some with biochemical and genetic diagnoses, maybe a family member that didn't. So there are a few clinical only diagnoses that made it into the database, 14 of them. 95 patients had a clinical and genetic diagnosis without biochemical confirmation. 565 had a clinical and biochemical diagnosis. 72 had a genetic and biochemical diagnosis, and 308 had a clinical, genetic, and biochemical diagnosis consistent with CTX. So when we look at those 873 patients, about 800 of them had xanthomas, which is a higher prevalence than what you've seen like from Dr. Wishart earlier today. And I will speculate on why that is in a minute. The prevalence of cataracts was close to 2/3 of patients. Diarrhea was about half. Osteoporosis, liver disease, and vascular disease were much lower in prevalence. In terms of neurological symptoms, you've heard from a couple of folks, Dr. Bonin, Dr. Wishart, about the level of granularity. So there's a trade-off that we have to make. So if we have a broad database, if we include a lot of patients, the broader we want this to be, the more superficial it's going to be, the more low resolution it's going to be. So this is a relatively low resolution look based on the breadth of the literature review here. So we found that of those 873 patients, about 550 had cognitive impairment. About half, a little less than half each had ataxia and spasticity. About 1/3 had psychiatric diagnoses. About 1/4 had seizures and neuropathy. Of those 873 patients, a little bit over 600 had any treatment at all documented. The vast majority of those were treated with CDCA. And about half of the patients who were treated with CDCA had any report of improvement. And we interpreted that pretty broadly. That was just any subjective impression on the part of the authors that there was some clinical improvement for the individual that was treated. So I want to compare this data set to some of the other publications and some of the other things that you've heard today. So you've heard from Dr. Dwell this morning, and this is a case series of 43 cases with really firsthand data. So what I'm talking about is secondhand data. And so in terms of thinking about the validity of this approach, are we getting accurate data from this this type of systematic evidence review? We can compare what the prevalence was of these different symptoms. So diarrhea was very similar, cognitive impairment similar, cataracts similar. Xanthomas is a little bit disparate, and I think my understanding of why that may be, when we look at these 873 cases, that includes some cases that were diagnosed 50 years ago. And when folks were diagnosing CTX 50 years ago, it had to be a pretty specific phenotype in order for people to identify that as CTX. So the diagnostic technologies that were available were very different. The use of genetic testing obviously was non-existent. And so for all those reasons, the patients that were ascertained and diagnosed would have had a much more specific phenotype. And when I say phenotype, that means just the clinical or physical manifestations of the condition. So the older the cases that we include, the higher the proportion of xanthomas are going to be. So that's my speculation about why that's the case. The reported improvements with treatment by the authors is very similar, and the prevalence of vascular disease is also very similar. Another publication to compare to see how we're doing with this systematic evidence review is this publication that just came out about 6 months ago. And this is by a group of authors from Poland. And so they also did a systematic evidence review. They included all cases that were published after the year 2000, which ended up being 568 cases. I think there's one thing to mention here, which is just that the numbers here are larger than what you hear. So if you read the introduction of a lot of papers about CTX, it will say there are 300 published cases or 400 published cases. So I think, at a very superficial level, it's helpful to kind of update that number in terms of the quantity of published cases. So 568 cases published since the year 2000. Again, that's if you do a very deep dive and include all of the single case reports that are out there. 873 cases total. Again, we see a pretty similar prevalence of things like diarrhea, cognitive impairment, cataracts. Again, the disparate numbers in terms of xanthomas, pretty similar numbers in terms of epilepsy as well. So it looks like we're capturing roughly the same picture of CTX, but just with this larger kind of catchment. One of the really important things to point out, and a couple folks have pointed this out, Dr. Wishart pointed this out, Dr. Bonin pointed this out, is that CTX is a slowly progressive disease. And so your impression of what the manifestations are of CTX is completely dependent on the age at which you're assessing that patient. So this is a paper that Dr. Wishart showed some graphs from earlier. Dr. Eichler is the senior author on this paper. He's here at this conference. And this group put together 194 patients. 134 of them had a biochemical diagnosis, 89 with a genetic diagnosis, and 80 of those 194 patients were treated with CDCA. And what they showed with a more sophisticated analysis than those previous papers that I showed you, which just give you kind of this cross-sectional impression of what the manifestations of CTX are, they show very nicely that all of these things are slowly progressive over the lifespan of an individual with CTX. And the older the individual is that we are assessing for manifestations of CTX, the more of the individual manifestations they will have. So the age of the population that you're capturing, anytime you do this kind of study, your impression of what the manifestations of CTX are is highly dependent on the age of the patients that are included. And that's true for both the neurologic symptoms as well as the non-neurologic symptoms. So when I think about now, we have this database, we have patient level data abstracted from 248 papers, over 800 patients. 475 of those patients that we have in this database have a genetic diagnosis. So that resource, I think, can complement some of the existing literature nicely, and sort of putting this resource together with existing publications, I think can help us to get at some of the data, some of the information that is needed for a successful application for newborn screening. So Dr. Bonin talked about the idea of underdiagnosis and using population level databases to maybe get a more accurate sense of what the true prevalence of CTX is. And so this, Dr. Bonin and some others in this room worked on this publication. This was published about 5 years ago, when our kind of gold standard database of population variation, population genetic variation, which used to be called EXAC, it's now called NOMAD. So at the time that this was published, that was about 60,000 individuals. It's now about 150,000, over 150,000 individuals. So it's almost triple the size. And in addition to that, it has higher quality data than it used to. We now have in one place the genetic diagnoses for 475 patients. If we use the same methodology with some additional published genotypes, that might be a productive way to use this. Some other ways to use this at the level of the genotypes might be to look at some atypical cases of CTX. So these are a couple of recent publications. In the upper left is a publication by Dr. Stelton and others that reported on 19 patients that had atypically mild or completely absent neurological involvement, but had a confirmed diagnosis of CTX. And they have the genotypes for all 19 of those individuals that had that atypical presentation of CTX. Likewise, Dr. DeBarber and some other folks very recently published a publication with 2 individuals with atypical biochemistry. And so when we try to answer this question that that will need to be answered for an application for newborn screening about what is the true spectrum of CTX or of CYP27A1 related disease, these outliers are going to be really informative. And we can use the genotypes potentially from these publications of outliers or atypical cases and refer that back to this, this data set that we have now. So the strengths and weaknesses of this systematic evidence review, by including case reports, the database is larger, it's more temporally and geographically inclusive. The size of the data set may help us to increase the sensitivity for detection of these outliers or atypical cases, whether that's atypical in a genetic sense, a biochemical sense, or in a clinical sense. However, there's downsides, right? There's always a trade-off. So the trade-off is that the data are very heterogeneous, and that this is mostly a cross-sectional and not a longitudinal data set. And I showed you the differences, just how important that is in CTX. The cross-sectional view is very different from the longitudinal view. The other thing is that, you know, including cases from 30, 40, 50 years ago, there were very different standards of care with regards to diagnosis and treatment and management of all of the manifestations of disease. So the natural history really is different over that length of time. So potential next steps for us in terms of using this are to try to use, we're not going to be able to get the resolution that Dr. Eichler and colleagues had in terms of the age-dependent penetrance of different manifestations of CTX, but I do think we can do a lower resolution version of that. I think that with the numbers, 475 genetically diagnosed individuals, I do think that we can start to tease apart some genotype-phenotype correlations. We can, in more detail, assess for biochemical and clinical improvement with treatment. We can, with 1,000 individuals, 873 with detailed documentation, we can really start to get at what the true rate is of adverse events related to treatment within the population of individuals with CTX. And as I said, we can look for those outliers, those atypical cases, and learn from them. So in summary, there are many more published cases of CTX than has previously been documented, including more genetically diagnosed patients. And a database with individual level biochemical, genetic, phenotypic, and treatment information can facilitate new analyses that will strengthen the application for inclusion of CTX on the RUSP. So I want to first and foremost acknowledge Hunter's Hope for providing the funding for the data abstraction for the systematic evidence review. And I want to thank the other folks that worked on this project, Andrea DeBarber, Bob Steiner, and the folks that aren't here who are listed on this slide.
Thanks very much. I think this will be a fantastic resource. I'm very excited about this. Do we have any questions from the audience? Or any online questions?
Can I say something?
Yep, go ahead, Mike.
Yeah, I think we have to be a little careful. We heard how CTX is underdiagnosed in the clinic. That's probably true. We have to be a little careful with these estimates of disease burden based on nomad databases. In that, I'm sure you know this. I think those are going to be the upper limit of the frequency, because not all combinations of pathogenic mutations will result in disease, right? So in cases of late onset mutations. So for a lot of diseases, if you have 2 late onset mutations, you may never get disease. And these late onset cases may be the result of a severe mutation in combination with a late onset mutation. So you need to know the phenotypic matrix for CTX, which you might not know yet, right? So I mean, when we say pathogenic, I think it's just too simplistic, right? It comes in it's a grayscale. So all combinations of pathogenic mutations are not CTX, right? Do you agree with that?
I do, yeah. So I think that there are different scenarios. So there are genotypes which clearly result in, so you have biallelic complete loss of function, 2 null alleles. I think that in a probabilistic way, we could say that there is a certain likelihood of penetrance by a certain age. And similarly to your point, I'm certain that there are mutations that have some residual enzyme activity, and you would change those variables. So you change the penetrance, the expected penetrance by a certain age. So, say 10% penetrance by age 30 versus 90% penetrance by age 20. So, it's that kind of probabilistic framework using those variables of age. So yeah, my impression is that that's an accurate statement. Yep.
Yeah. So I think the real estimate is somewhere in between the clinical diagnosis and the nomad prediction. I think so. I think you want to be careful not to oversell the nomad, because I think people will say you're overestimating CTX, and that's not right. So the RUSP people might say that. So we got to be careful. But I think this is true for all diseases. I think, yeah.
Well, I was just going to say that. I think, there are a number of recent publications that have overlaid the information from a biobank with the information from the electronic health record. And in almost every case, you do not see the signature in the health record of the burden of disease that you would expect based on genotyping the individuals in the corresponding biobank. So to your point, as a general rule, it's likely that the vast majority of diseases are less penetrant than we think they are.
Yeah, it's just, same old problem. Pathogenic is too simplistic a word. And, yeah. I mean, for MLD, we have a paper coming out. We've tried to cluster, severe mutations, moderate and mild. And you tend to see in juvenile MLD patients, we tend to see a severe and a moderate. And in adult patients, we see either two moderates, but or a severe and a mild. But mild and mild, we never see MLD, right? So you can imagine a case where you have a mild CTX because they have a severe and a mild variation, and you might call both pathogenic. But the mild, if you have mild 1/mild 2, they probably never get CTX. You can imagine that kind of scenario, right? I think that's true for all diseases. Yeah. Does that make sense? Yeah.
Absolutely. Yeah. And I think that's
okay.
that's a
I think that's just, yeah, I think everybody agrees. Yeah. Okay. Yeah.
Great, thanks very much. And so this is a nice segue into the talk from Dr. Joseph Orsini, who will provide an update to us on another a prospective pilot study that's screening New York State newborns for CTX.
Just trying to get my screen shared. Can you see it properly?
Yes, yes.
And can hear me okay? Great. Okay, well, thank you very much for the invitation. I've really enjoyed all of the talks and appreciate the opportunity to be here. I'm sorry to not be there in person to meet some of the people that are involved with CTX. My expertise is in newborn screening, and so I really know very little about CTX and was happy to learn more about that. So what I wanted to talk about here, what was asked to talk about, is our pilot screening project. And CTX is one of 14 disorders where we're screening. So what is the Screen Plus pilot? I'll just give you a little bit of an overview. This is a consented, population-based, considered a research study to assess the suitability of specific disorders for public health mandated screening. And that is really, what is the suitability to get this on a RUSP? How well does it work kind of in high volume testing? What are long-term follow-up and ethical and legal and social issues that are associated with performing the screening? So we are doing, by consented, it means we're asking the families if they would like to participate in this process. So some of the overarching goals of Screen Plus are to evaluate the analytical and clinical validity of the screening assays. We're currently running 2 assays. One for markers such as the CTX assay and one for enzyme activity measurements. We're working on combining those 2 to hopefully make there be one assay. And one of the big questions is what are screen positive rates? What are the possible incidence rates? Things like that. But it'll be a little tricky for us to get the incidence rates just because of the numbers of patients we'll be screening in this process will be small relative to what you do in real live screening, like in New York, and I'll tell you a little more about that later. The other thing is to determine the impact of identification of the MBS on the phenotype and outcome. So how well do the children do when you detect them earlier, which I think is always important for some of these disorders. That's not an easy task to do. We hope to get enough numbers to be able to have data there. Again, that's always the hard part with small volume. Then I think what makes this really unique is examining kind of this ELSI, or ethical, legal, and social issues associated with screening newborns for complex disorders. And I'm not saying CTX is necessarily a complex one. This may be one of the ones that seems easier of the bunch. But one thing that does make it somewhat unique, or in the newborn screening world, is it is generally a later onset phenotype. So a lot of newborn screening, we're looking for things that would develop in the infancy and not later in childhood or into adulthood. And that part of it makes it trickier, and we want to know what the public thinks about that. So there's questionnaires and things like that that we'll be distributing for that purpose. So these are the 14 disorders you see. And the criteria is that there's a method or a way to do the screen that has is relatively cheap. So all of these individual disorders fit that criteria, as well as morbidity or mortality if untreated, a pediatric phenotype. So something, at least in childhood, with phenotype, and then an FDA approved therapy and or another therapy that's in clinical trials. So one of the things that Screen Plus is doing is looking kind of at a multi-tiered approach for as many of these disorders as possible. So with CTX, we're looking for elevated bile G-tetrol that Dr. Vaz mentioned. And there's a second tier Mayo test that's currently being done where we'll send out the dry blood spot for second tier testing. And then we do molecular testing as well. And we're trying to combine all of this to get up an idea of how well the test is working. What are how does molecular data, what does it say compared with what's known in the literature? Are they cases that you might expect in earlier infant or earlier diseases? And all of this maybe is more important for some of these other diseases, but to reduce false positives, predict phenotype severity, and we're looking at combining all of that data to get a better feel for what it means. And then how do we determine referral cutoffs? So as we started screening, we start with conservative cutoffs, and what we end up doing is evaluating the molecular and any second tier biochemical data and help us adjust cutoffs over time if we're getting too many positives. And that's a process that we go through with the pilot screening. So the screening algorithm here is actually quite a bit simpler than Fred talked about. Doesn't mean that it couldn't use improvement, but this is where we're starting. We're actually just looking at G-tetrol as the marker, primary marker. We are monitoring the TDCA marker as well. So we can look at the ratios, and we will use that as we get more experience. One of the issues really is knowing where that ratio should be. And I think using the data that Dr. Vaz had would be helpful for us and other data that's been published. But for now, we're just picking the primary marker for a cutoff. And so far, we're not seeing a lot of positives, although we have very small number tested, as you'll see. So we look at anything above 0.01 micromolar and just verify that the peak is integrated properly. And we have seen one instance where we had a split peak, and we think that ended up giving us a lower concentration. So it would obviously give a lower concentration. So that was our kind of a kicker for let's just set up something to be a little more sensitive in the testing phase, because we anticipate, we don't want to look at so many integrations. We want to be able to have this flag positives for us more simply than have to look at every peak in that we're analyzing. And then we do look at the ratio, should be very elevated as you expected, but if it's not, we're still moving forward with analysis for some reasons, and I'll explain a little more of that later. If the average of the 3 samples is above 0.02, we'll send for second tier and biochemical testing simultaneously, just to, again, get a better understanding of where our cutoff stands. So the screening results as of May 17th, only up to about 1,200 samples. And I say this is, we have 10 hospitals that have agreed to be part of this process, but we've only been running with 1 hospital live. And it's been a large part of the problem has been getting the contract set up for all the hospitals, and then getting a coordinator. Now we're in the process of hiring coordinators for hospitals. We anticipate having 3 more hospitals up here shortly. And the other aspect has been COVID really stalled us for a good amount of time with the hospitals not being able to have contact with families. And it's required. We've been working on making it easier to get consent without being in contact with the families. So far we had 2 positive screens, and both of those were actually from the same baby. Interestingly, the initial baby had normal G-tetrol, but then there were 2 repeats afterwards that were elevated. And in this particular case, the tetrol and the TCDA were elevated. So it was not really consistent with CTX. We understood that. So one of the things we found out, it was a false positive and was a case of neonatal cholestasis. So that's got a fairly high estimated incidence. We're not really certain what this will play as far as screening, but apparently it's not too bad based on the results of Gelb's lab and Vaz's lab so far. One of the questions then is, when you have elevated marker, should you be pursuing, and what is the diagnosis, and should we be concerned with these cases? So that's something that will come out, being that our states are a little less sensitive to the issue of detecting other possible cases than maybe the Netherlands. And for example, we screen for ALD and we do pick up Zellweger cases. So we're already in that situation. And we did find a Zellweger case and we ran it on this test and we did see that it is positive for the TCDCA marker. So it was that was interesting. So what's the long-term follow-up process is another part of this is how do we want to follow these families? So when you have a family with a newborn that's detected who's positive, what kind of follow-up is required, frequency of visits, when should treatment be done? Based on a lot of information that we'll be trying to gather through the process of screening. And we're also working on newborn screening translational group to get a better idea on that long-term follow-up kinds of guidelines. The LC surveys, as I mentioned earlier, part of it, we're going to have a large number of people. We're trying to find out their thoughts. There's a lot you can learn about this if you wanted to go to the Screen Plus website. I'm just presenting it shortly here. But some of the questions we're really interested in are how do families feel about having diseases detected that may not present until later in life, which is often considered not a good thing in newborn screening. So what are some challenges we've been having with this test? Some of the method validation requirements that we're going through is it's very simple to kind of create educational materials, specimen collection, all of that. Where we end up running into more difficulties is with our quality assurance and QC materials and having the best materials. We need to work on that. And when we set up this screening, we had to actually put all this information together and get approval from New York State's clinical lab evaluation program. So that's part of the process. Another part is validating the assay. So this is something other labs have done, but we have to prove it can be done in our hands as well. And we do a lot of this precision and accuracy. So run many samples with spiked values. What is the reportable range, limits of detection, and some cases, sensitivity and specificity where we're reporting what other people are finding and not what we've found because we haven't done enough testing to know these things. So that's all part of our challenges in setting these up. After validation, we did a lot of what other people have done, running anonymized specimens, setting our preliminary cutoffs. We've only actually had a couple of positives we were able to test, and they met the criteria of reported cutoffs that Andrea had and Mike had put in the literature. But it would be very beneficial for us to be able to run more of those specimens. So if anybody has access to newborns, I think Andrea asked for people to make mention of those so that they could be available for any newborn screening lab developing this test. So because we are working with limited data and positive controls, and that's where we start off with these conservative cutoffs. Some unique issues with pilot screening I want to talk about. We're only testing a subset of the samples that come in. So New York receives about 1,000 samples a day, and we're going to be probably doing somewhere around the order of 20 to 50 a day that are pilot screened as we get scaled up. So one of the things we have to worry about is not delaying all of our other screenings. So what we end up doing is running these samples after we've reported all the other data, and then we go and we punch these specimens. So that's one kind of inhibitor. It makes it a little bit off process because you have to pick samples as, not in sequential order. They're kind of in bunches based on where they came from, which hospitals. But then we have to go across the whole day and punch them. We're using 3 punches to run this assay, which is a fair amount. It's been minimized as best we think at this point, but getting it to be a smaller number of punches would be better. We're combining later on with other tests, for example, like Dr. Vaz did with running it in with the amino acidase or carnitine testing. So we have a little bit of delay in our testing. We're monitoring and resetting cutoffs based on our first or second tier molecular data. And one of the questions is really, right now, I look at this as we don't have a perfect screen per se in our lab because we don't really know where the cutoffs are. We don't have the best idea of how it's going to work for all 14 disorders, but we're very happy to be testing these because there's really zero chance of detecting anybody with these disorders without the screening. So it's a process that New York has been very happy to be involved with. So that's the last question is it better to screen for many tests that are less than perfect and, get to a point, I think, where you can at least detect that many more diseases. This is something that's out there now in the newborn screening world is how do we add more tests? There's a lot of pressure to add tests. And one of the things about newborn screening, we never want to miss a case. And well, if we aren't screening, we're missing all the cases for those diseases we're not screening for. So it's just some food for thought for people that might be out there. This is my acknowledgement slide. First and foremost, I'd like to thank Dr. Melissa Wasserstein. She's the principal investigator and the one who dreamed up this project. We built a test quite a while ago based on what Dr. Gelb had published. That was some original pilot screening that was done in New York for lysosomal storage disorders. And that project worked quite well. And it was Dr. Wasserstein's idea to, while they've gotten this assay, we'd like to do some pilot screening. So now Mike has turned kind of into a pipeline, or Dr. Gelb has turned into a pipeline for developing assays. And this Screen Plus project's a way of testing them out. So we get to work with people that are very smart at developing tests, people that are very smart at working on the clinical aspects of these diseases. And we also get to work with ethicists. So this has been a very interesting project. And our part is really just trying to prove that we can run these assays large scale and for multiple disorders. So with that, I thank everybody again for their attention and opportunity to give this talk.
Well, thank you very much for giving this very interesting talk, Dr. Orsini, and we're so thrilled that CTX is part of the diseases being screened for Screen Plus. And so I'd like to open it up to questions from the audience.
So I have a question and a comment.
Okay.
First of all, great project. I have a question and a comment about the neonatal cholestasis. Did you follow up that case with the second tier biochemical and the third tier DNA to rule out CTX completely, because CTX obviously can cause neonatal cholestasis?
Yes, we did not find any variants in molecular. We do Sanger sequencing and no variants were detected. And it was not by second tier testing considered CTX from the Mayo Clinic's test. They actually thought it might be the cholestasis. And then sure enough, well, I mean, the other clue I'd say was that at the time of the very initial specimen where the G-tetrol was not elevated, we wouldn't expect that in a true CTX case.
And likely the CDCA was also high. So the ratio of the tetrol divided by the CDCA will be low or normal, which is another benefit of using the ratio, because you don't get these cholestatic cases making potentially
Right.
positive.
Yep.
And I think there's the opportunity to learn a lot about neonatal cholestasis in your project. Firstly, you have at least 3 disorders on your panel that can cause neonatal cholestasis: Niemann-Pick C, LAL deficiency, and CTX. And if it's really, 1 in 1,200 prevalence, you may learn a lot about neonatal cholestasis as a byproduct of your project.
Yeah, that's a great point. And I think that's one of the things we want to learn is when you're evaluating these markers, sometimes you do detect elevated markers, especially when you do a marker analysis, and trying to get to the bottom of it can lead to some interesting findings. And that happened with when we were doing ALD screening, and we found the disorder is not coming to me, but we found another disease that was totally unexpected, had elevated C26 LPC marker.
Okay, well, I'd like to thank all the speakers again here present and remotely for giving a fantastic morning of talks here. So thanks very much, and we'll be having a lunch now. So if everyone looks out for the tables with the CTX Alliance signs.
They're in the back of the cafeteria area, the back room. They're marked.
And feel free to ask any additional questions. All the docs will be here for the lunch. So look forward to continued discussions over lunch.
And I have one more favor to ask. If you could all be so kind as to come up to the front of the room here, I'd love to get a group picture of everybody together here. It's a unique opportunity, and we want to make sure we capture it.
And we stayed on time. Thank you.